Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their care providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted enough time to answer as many questions as possible. Today's webinar, Pituitary, Tumors, and Brain Fog, is presented by Dr. Garni, Boukhardarian. Now please hold as there will be a brief delay while we change presenters. Thank you.
All right. Well, thank you so much for the kind introduction. Appreciate being invited to speak at the Pituitary Network Association webinar series on a topic that I feel is very important to our patients, and yet at the same time under discussed and under appreciated by most people, particularly on the surgical side, but I think overall with regards to pituitary tumors, and that's the topic of brain fog. And I will say that's a common complaint that I get when I see a patient with a pituitary tumor, is that they have some level of brain fog and they can't explain it, and it's something that's been subtle and insidious and slowly getting worse. And so it's very much an important aspect, as many patients will agree with, and I hope that we can talk a little bit more about some of the various mechanisms of brain fog and what we do about it, and also how to take care of these issues. These are my disclosures, none of which are relevant to this topic. So this is the outline. We'll start by some symptoms with pituitary tumors. We'll talk a little bit about some of the normal anatomy and physiology of pituitary gland and the hypothalamus. We'll talk about hypopituitarism, including non-functional tumors as well as functional tumors. We'll talk about hormone excess and also craniopharyngiomas. So what are some of the typical symptoms of pituitary adenomas? The classic ones are pituitary gland failure or hypopituitarism, which we'll talk about in some depth, which can present with fatigue, weight gain, weight loss, depression, decreased libido, impotence, infertility, loss of menses, cold intolerance, and there's probably 30 or 40 more symptoms that go along with that. Vision loss, particularly peripheral vision or this bitemporal hemianopsia, as you can see on this image here from this large tumor, can affect visual acuity, could even cause double vision, can cause headaches, often frontal orbital, midline, and location, and in some urgent cases can present as apoplexy with rapid onset of these symptoms related to bleeding in the tumor. So these are the typical symptoms that people complain about. For hormone active or hormone secreting tumors, where acromegaly can affect, of course, altered facial appearance, enlarged hands and feet, sleep apnea, carpal tunnel syndrome, hypertension, diabetes, colonic polyps, amongst other things. Cushing's disease, which is excess ACTH and cortisol, would be weight gain, facial rounding or moon faces, stretch marks, hypertension, diabetes, osteoporosis. And prolactinomas, which is excess prolactin, loss of menses, breast milk discharge in women, loss of libido, sexual dysfunction. But what are some of the cognitive symptoms? So this brain fog, that's this ethereal type of symptom that people complain about. Well, cognitive delay, malaise or fatigue, depression, those are all different categories that brain fog can fall under. And it affects not an insignificant minority. About 25% of pituitary tumor patients have some level of these symptoms. And it could be from a small tumor or a very large tumor. So let's talk a little bit about some anatomy here. So the hypothalamus is really the key aspect here. It's located in the third ventricle, surrounded by critical structures like the thalamus, lamina terminalis in front, and is just above the pituitary gland, which hangs beneath the hypothalamus. and that has multiple parts, including the pars distalis, which is the anterior pituitary lobe, the pars intermedia, and then the pars nervosa, which is the posterior lobe, and they have different functions. And there's also a combined area, which is basically the infundibulum or the stalk, which is called the pars tuberalis. There's a number of blood vessels that feed the hypothalamus and the pituitary gland, and there's some overlap in how they are shared. In particular, there's the portal system. So the blood supply starts in the hypothalamic region with the superior hypophyseal artery, and the venous system drains from the hypothalamus and the median eminence portion of the third ventricle, which is the bottom part of the hypothalamus, to go down to the pars distalis, or the anterior lobe of the pituitary gland, and then get back into the bloodstream. So this is that internal feedback cycle where the hypothalamic hormones are controlling or regulating the pituitary hormones. And so this is a critical way of how the pituitary gland functions. Vascularly, there's a number of different small perforators that feed the pituitary gland and the hypothalamus, and it's key to see in this location, and let me see if I can get my pointer to work. Here we go. And so you can see here, some of the feeders will come to the infundibulum, as well as to the bottom of the hypothalamus. These are the mammillary bodies, which are pretty far back in the hypothalamus. There's also shared blood supply to the optic chiasm and the optic nerves and the optic tracts, with all of these perforators coming off of the carotid artery and its branches. The pituitary gland develops from the diencephalon as well as the ectoderm, so they meet. So the posterior pituitary gland is brain tissue, and the anterior pituitary gland actually comes from the same tissue that develops to the roof of the mouth and the paranasal sinuses. Rathke's pouch is the developmental outpouching of the ectoderm, and here we see as it develops, it outpouches superiorly. The diencephalon, which becomes, that portion of the brain comes down, and they meet, and that point where they meet is called Rathke's cleft, and there are certain pathologies that can occur in there. The hypothalamic nuclei, I won't go into too much detail, but this just shows the governance structure of the hypothalamus. The hypothalamus is a very complex and yet very compact structure that we still are grasping, and it has numerous different areas. So the preoptic area, which is this area right here, is separated from the supraoptic region, the tuberal region, and the mammillary region, so you can divide them superiorly. There's also a medial and a lateral, which we'll talk about. But there's various nuclei, the medial and lateral preoptic nuclei, these 4 nuclei in the supraoptic region, these 3 in the tuberal region, and then the mammillary bodies and the posterior nuclei. So they're all topographically oriented. And then there's also on the coronal plane. So there's medial and there's lateral. All of those nuclei I showed were all medial. And then there's a significant number of lateral nuclei that include the medial forebrain bundle, which is out here, that is really critical for memory and cognition. So you can imagine any pathology in the pituitary, in the hypothalamus, can result in significant cognitive dysfunction, as you can see here. So what are some of the hypothalamic functions? So there's a lot of yin and yang or push and pull that we see in the hypothalamus, and it's divided often from caudolateral, so outside and superior, versus rostromedial, so inside and lower in that location. So caudolateral anxiety, rostromedial contentment. Anterior nuclei tend to be more of the calming down, so parasympathetic, lowers the temperature. The posterior nuclei tends to ramp things up, so sympathetic tone, increased temperature and anxiety. And then the lateral nuclei is where the feeding center is, where it helps drive appetite. And then the medial nuclei is satiety. And there's also the dorsomedial, which is aggressiveness and sham rage with stimulation. So these are all the different aspects in the hypothalamus. It's a very delicate balance. So if these are thrown off, you can have various dysfunctions. And one of the dysfunction in the hypothalamic era, or hypothalamic dysfunction, is cognitive dysfunction. So we'll talk a little bit more about that, especially as we get into the craniopharyngioma topic. So Also, the posterior gland is innervated by the paraventricular and supraoptic nuclei, and so these actually are part of the brain that goes directly to the pituitary gland, and this governs thirst and ADH release. So this is the part of the hypothalamus that governs what we call diabetes insipidus, or prevents that from happening. And if the hypothalamus isn't working, then you can have the very difficult to manage adipsic diabetes insipidus, where you not only lack fluid balance control, but also the thirst drive to maintain your own endogenous intake. And some of the releasing hormones are in these nuclei, which I won't get into too much. But these are the key aspects of hypothalamic function as it relates to pituitary gland function. Well, how does the pituitary gland get regulated? Well, it's this negative feedback loop that we talked about briefly. So the stimulus comes from the brain down to the hypothalamus, down to the hypophysis, which is the pituitary gland. And this makes a hormone that then regulates the target organ. And then the target organ will give some feedback back to the brain, hypothalamus, hypophysis, alongside the hormones that were generated. So there's this negative feedback for the majority of the hormones that we have. The different hormones include FSH and LH, which govern the ovarian cycle in women and govern sexual function and sperm production in men, and then and testosterone production in men. The adrenocorticotropic hormone, which governs cortisol release by the adrenal glands. And this is made with a precursor called pro-opiomelanocortin, or POMC, which also makes melatonin, which is what pigments the skin. There's thyrotropin, or thyroid stimulating hormone, which governs the thyroid gland, and that affects metabolism throughout the body. Prolactin is one of those hormones that does not have a negative feedback loop. It's actually inhibited by dopamine that's made by the hypothalamus. And so if there's lack of dopamine, or if that connection is severed or affected, then you can have increased prolactin production. And the prolactin is affecting the mammary glands to make breast milk. It also is a negative feedback inhibitor for the FSH and LH hormonal system. And finally, growth hormone, which actually stimulates the liver to make the IGF-1, or insulin-like growth factor type 1, or somatomedin C, which then both of those hormones affect the entire body in production of increased tissue, bone growth, muscle growth, as well as red blood cell development, etc. So really critical hormone, both while you're growing as well as after you've stopped growing vertically. You still require some level of growth hormone that affects quality of life. Well, we talk about excess of these hormones. So there's Cushing syndrome versus Cushing's disease. So Cushing syndrome is excess cortisol. That can happen most commonly due to us physicians, prescribing cortisol type drugs. That's the most common cause of Cushing syndrome, but adrenal adenomas and pituitary adenomas through true Cushing's disease can occur, and some ectopic ACTH production can also develop and result in Cushing syndrome. Signs and symptoms, we talked a little bit about this. I won't go into too much detail, but one of the signs here is cognitive decline, and that's something that, again, should not be taken lightly. How do we make a diagnosis? We assess ACTH and cortisol. We do a number of tests to evaluate cortisol levels. We can do a suppression test to evaluate if the cortisol is coming from the pituitary or not. And then we get high-level imaging to determine if there's a tumor in there or not. If there is no obvious tumor, then we may do petrosal sinus sampling to see if it's central or ectopic ACTH production. And the treatment, the gold standard is we're taking out the tumor. If you can't see the tumor, performing a hypophysectomy. And medications are quite effective these days. And of course, adrenalectomy is kind of the fallback, although that has its own level of morbidity. For thyrotropes, central deficiency, so basically low thyroid can cause fatigue, weight gain, cold intolerance, etc. But it definitely can result in cognitive decline. The depression and dementia go hand in hand with low thyroid. Well known that low thyroid levels should be checked in somebody with chronic depression or cognitive decline, because that can be quickly reversed with thyroid replacement. And the diagnosis, there's certain levels of T3 and T4 that we assess, and the TSH typically is low in people who have central causes of hypothyroidism, as opposed to thyroid dysfunction, thyroid gland dysfunction, where the TSH would be elevated. And the treatment, of course, is replacing with medications. Most commonly is Synthroid, but Armour thyroid can be used, or in some acute settings, T3 can be utilized, which is the active version of the hormone at much lower doses. ADH, so antidiuretic hormone, maintains water balance, and the sodium is really just a marker of fluid status, but it's really about how much water you have. I won't go into too much detail here, but if you have too much ADH, you'll end up gaining too much fluid, and your sodium levels will drop. That can cause cognitive decline. And then postoperatively, we sometimes see too little ADH, which causes diabetes insipidus, which you have increased thirst and urination. Oftentimes you have to differentiate between nephrogenic and neurogenic, but for the neurogenic type, which is typically seen after these types of operations, you have to give back the ADH, otherwise the sodium levels can increase, and that, in addition to other symptoms, can cause cognitive decline. So let's take a look at all patients with pituitary gland dysfunction with pituitary adenomas, and evaluate from a cognitive perspective. So this was a study that was published a couple of years ago in a Neuropsychological journal that demonstrates that preoperatively there was a significant portion of up to 25% of patients had some level of cognitive decline relative to controls. And postoperatively, some of these improved, some of these remained the same, and some of these worsened. So it's a wide range with regards to verbal, visual, as well as psychomotor speed, reaction time, etc. But there is a significant association with cognitive dysfunction and having a pituitary adenoma. This was another study published in the endocrine world that showed the effects of radiation on pituitary tumors. And you can note that actually post-radiation actually most often made things worse from a cognitive perspective, and partly because there is significant pituitary gland and potentially even hypothalamic effects of the radiation, which can result in cognitive decline. These are patients with hypopituitarism, and overall there was a notable difficulty in word recall in a number of their patients, particularly in the 50th percentile. You can see statistically significant difference affecting women more than men, surprisingly. And this was a study that came out by Dr. Berman and Dajan that noted that overall, the quality of life in patients with pituitary gland dysfunction was significantly worse with relation to control. The number one issue is energy, as you can imagine, but emotional insufficiency was notable in about 25% of patients. Social isolation, sleep dysfunction were all issues that were identified in these patients. And then you can even see iconic memory and short-term memory were significantly affected in patients with pituitary gland dysfunction relative to controls. So let's talk a little bit about Cushing's disease. This is a slide that I borrowed by my mentor, Ed Laws, and Dan Kelly. And this is Ed Laws here. This is Jules Hardy. And these are some of the progressions and some of the advancements we've had, recognizing that many times Cushing's disease can be cured or at least brought to remission by taking out the adenoma selectively. Well, here's a patient who had classic signs of Cushing's disease. She had a microadenoma, and there she is years later with more appropriate facial changes and weight loss and some of the cognitive improvement. But take a look at this patient. Look at the patient on the left compared to the patient on the right. You can see a lot of thinning here, cortical atrophy, increased ventricular size, just overall thinning of the brain compared to this. Actually, this is the same patient. This is a 19-year-old patient who had significant cognitive dysfunction due to severe Cushing's disease. And this is her same brain 1 year after surgery, and you can see significant improvement in just volume, and she actually had improvement cognitively as well. So this has actually been studied in significant depth, and you can see the volume of the different aspects of the brain. So these are different anatomical structures in the brain: caudolateral, precuneus, postcingulate, etc. And you can see the controls had a significantly more robust size relative to the patients with Cushing's disease. And there was a notable correlation with disease duration and remission with cortical thickness. This was also looking at cognitive function pre and post-op for Cushing's syndrome, or pre and post-treatment with Cushing's syndrome. And you can see that a lot of the cognitive tests that were performed were significantly worse before treatment, but they actually did improve, just not back to normal after the treatment was performed. What about acromegaly? So this is a patient with acromegalic gigantism. There's my partner and mentor, Dan Kelly, and he operated on this acromegalic giant patient who had a large pituitary macroadenoma. We do know that even if you can't take all the tumor out, although that should be your goal, there is actually a correlation with the extent of resection and how well medications can work to control IGF-1. So IGF-1 is really the key aspect in controlling acromegaly. And here's a study that looked at quality of life with treatment of acromegaly, so normalization of IGF-1, and you can see a significant cognitive issues that were difficult but still able to be normalized with treatment. So the yellow circles versus the black squares, including motivation, activity, mental fatigue, general health perception, mental health. These are all different questionnaires that tended to normalize with treatment of IGF-1. So significant findings in a number of these patients. Neuropsych testing in prolactinoma also noted significant verbal and nonverbal cognitive dysfunction, particularly in the verbal memory and attention. And this was notable that improved after treatment of dopamine agonists or after surgery. So those are the pituitary adenomas. A less common but equally prevalent or equally important tumor is a craniopharyngioma. It's about 2 to 4% of all primary brain tumors and about 10 to 15% of pituitary location brain tumors, with affecting kids as well as the elderly. And it's in 55% of children is the most common tumor. There's two types, adamantinomatous and papillary, which up until a few years ago was just more of an academic thing, but now we actually know that there's treatment options for the papillary subtype in addition to surgery. This is the history of craniopharyngioma mortality. So famously, Harvey Cushing stated that this was the most formidable of tumors to take out of the brain. He actually had a very good series in the 30s that he had published with relatively low morbidity and mortality, but you can see, nearly 100% of people died over 100 years ago. Even 50 years ago, there was still about a 25% mortality. There was a number of advancements that helped us. So penicillin, so antibiotic management. Corticosteroids was really key because a lot of people died because they went into Addisonian shock or crisis. Radiosurgery was developed in the 1950s. The operative microscope in 1957, Jules Hardy popularized that for pituitary tumor resection. And then high-level imaging with computerized tomography and MRI imaging really helped us get our mortality from nearly 100% in some series, but really about 15 to 25% in most series in the early first half of last century, down to less than 1% or so in modern contemporary studies. And these are some of the main aspects that we talked about. Craniopharyngiomas are commonly approached through the nose because of this avenue that we see, that allows us to reach the tumor from the endonasal approach, which because it's nestled between the pituitary gland and the optic chiasm, so it's a nice avenue coming like this to take these tumors out. But you can note, based on what I showed you earlier, that is sitting right in the middle of the hypothalamus. So this is an area where you can have significant hypothalamic risk and injury if not taken with appropriate precautions. So this is an approach we take for craniopharyngioma. This is called a transtubercular approach. So we see the pituitary gland and the suprasellar region. We make a connection here. We cut open the circular sinus here. We're seeing the top of the pituitary right there. We open up and we see the pituitary tumor, which is in this case the craniopharyngioma. You can see the infundibulum on the patient's right side, which is left of our screen. And we preserve the infundibulum. We don't want to cut into the gland unless we absolutely need to, but we're able to carefully dissect, come around the capsule, and carefully dissect this tumor away from the surrounding structures. You can see how the tumor is intimately associated with those tiny vessels I was showing you. This is the superior hypophyseal arteries that are feeding both the optic chiasm and the infundibulum. So we spend a considerable amount of time working to carefully preserve these vessels. They also, some of these vessels, not those particular, but some of these vessels supply the hypothalamus. And we want to make sure we preserve these vessels to avoid hypothalamic dysfunction. The hypothalamus is living in these walls on the outsides here. There's the mammillary bodies. The hypothalamus is sitting right there. And we want to make sure we preserve the hypothalamic walls. And I would advocate to leave a little bit of tumor behind on the hypothalamus to preserve hypothalamic function rather than try to get all of the tumor out and have hypothalamic dysfunction just because of the morbidity of that, particularly from a cognitive and a physical health perspective. And so we spend all this time very carefully peeling this tumor off of the normal structures to try to get a maximal safe resection of this tumor here. And now you can see the optic chiasm, hypothalamus up there, the brainstem, all are well preserved here. And then we complete our closure. I mentioned that there was a unique aspect to papillary craniopharyngiomas, and this was a study from 7 years ago that noted that some of these papillary tumors had the BRAF V600E mutation, which is a very specific mutation of the BRAF protein that has been characterized already in melanoma and some other known cancers. And so there's a drug that already existed for this, and the majority of patients with papillary type, so often more the adult population craniopharyngiomas, had this mutation. And this was a patient who had multiple recurrences, had been radiated, was set to have, I think, either a fourth or fifth operation to take this craniopharyngioma out. And they decided to try this drug. And in 2 weeks, just getting the planning scan for surgery, the tumor had shrank significantly. They obviously didn't operate. In 1 month, it was significantly improved. And you can see a significant decrease in the volume of the size of this tumor. We looked at our craniopharyngioma series, and of our 48 patients, we had 57 operations. And you can see our resection rate. So we try not to go for it all because we know that the hypothalamus is involved. We do not want to deal with hypothalamic dysfunction. It's so morbid for patients, both cognitively as well as physically. So we aim for mostly a near total resection, in some cases subtotal resection, which is 95% or less than 95%. And the majority of our patients had this adamantinomatous or diamond-like pathology, but we did have up to 30% of patients with papillary subtype. Our patients had significant improvement with visual outcome, with only 2 patients had worsened vision and no significant blindness. Unfortunately, the majority of our patients did not gain any pituitary gland function. We don't really expect that, but there was a significant loss of pituitary gland function up to 1/3 of patients. And only 1 patient with preoperative diabetes insipidus actually improved. We had 2 neurological deficits. One was vision loss due to a PCA branch, not the superior hypophyseal, and 1 humeral artery infarct after a craniotomy. We had 5 CSF leaks and only 2 patients with meningitis, and this number has come down as we have become more facile with our reconstruction. About 31% of patients had recurrence, that some of which required reoperation. The majority were treated with stereotactic radiation therapy or radiosurgery. Some people required a craniotomy as well to get there. So one question is, should we cut the pituitary infundibulum to help prevent traction on the hypothalamus? So that was one question that was somewhat dogmatic. And so we want to avoid hypothalamic obesity, loss of circadian rhythm, cognitive dysfunction, and the adipsic diabetes insipidus that can occur. Well, so we looked at this, but we obviously don't have a great marker for this. So we use some surrogate markers, including BMI, body mass index, and the Karnofsky performance score, KPS. And the higher the better for Karnofsky, and the lower the better for BMI. And you can see that these were significantly improved, significantly affected in patients postoperatively. You can see preoperative versus postoperative. There was a notable change in worsened BMI in these patients, and the median increase in BMI was 2 points. So significant worsening. It could be due to steroid replacement, but a lot of it was due to hypothalamic dysfunction. And you can see here the postoperative KPS was significantly worse here. We did have a patient, a significant adipsic DI as well, which is also another marker of hypothalamic dysfunction. And we did not notice any correlation with infundibular sacrifice. So we decided that that's really not the way we want to go. We aim to try to preserve the infundibulum and the pituitary gland as best as possible, unless it's completely obliterated by the tumor. This is a patient that had the surgery for his craniopharyngioma. He had preoperative preoperative bitemporal hemianopsia. You can see this on the visual field test. Postoperatively did well. He had recurrence relatively quickly, within 3 months of surgery. But because it was a papillary craniopharyngioma, instead of going straight to radiation, we decided to treat with BRAF treatment first. And you can see how quickly this tumor shrank in 6 weeks, significantly smaller, with improvement of his visual field deficits, and just a small residual that remains at baseline currently. This is now, I believe, 4 years after surgery. And he did develop a side effect from the BRAF medications, where he developed a little bit of fluid underneath the retina. Retinal central serous chorioretinopathy is what that's called. It's a known side effect of the BRAF medications, which went away when we decreased the dose. So this is dose dependent, and his vision improved after a couple of cycles there. And finally, hydrocephalus. That's an important factor for both craniopharyngiomas and pituitary macroadenomas. Hydrocephalus is basically water on the brain. And you can see that the fluid-filled structures that are within the brain, the ventricles the lateral ventricles connect to the third ventricle, which then drains down to the fourth ventricle. A lot of pituitary pathology is right here. So if you have blockage of these, you can get large ventricles, which can cause brain dysfunction. There is no off switch for the development of the cerebrospinal fluid, which can happen across that choroid plexus, that kind of pink structure there, but there's really no off switch, so there's no way to stop it other than to relieve the obstruction. So oftentimes it's taking out the tumor. So this is a young child, 6-year-old boy who had a large craniopharyngioma. You can see significant dilation of the ventricles. These are much larger. They should be almost split like in a child. They're significantly enlarged with fluid coming through the brain. He had progressive vision loss, pituitary gland failure, with a catheter temporarily placed, but really just taking out this tumor. The patient's symptoms improved significantly, and you can see what the normal ventricle sizes should have been from this perspective here. So that's really one mechanism to help control hydrocephalus, which can affect cognition. Here's another patient, 62-year-old man. He had a known pituitary adenoma taken out elsewhere about 13 years ago. That was being monitored, he was doing well, but then he just stopped getting MRIs. And then 5 years after his last MRI, so in 2018, his wife noticed cognitive decline. He had panhypopituitarism, that was kind of known. He had this recurrence of his pituitary macroadenoma. He had actually developed hydrocephalus, and a surgeon had placed a shunt to help manage this. But he also had vision loss, and we recognized that this tumor needed to come out. This was his optical coherence tomography that showed already irreversible vision loss in the bitemporal fields. kind of knew that that was already the case here. And here is the surgery here, where we come in. A lot of this is scar tissue. And let me see if I can advance this here. There we go. So a lot of this is scar tissue, so we're just opening up. We get into the tumor. This is the dura covering the tumor in this location here. We are able to come around this and we start debulking into the tumor. The tumor is actually somewhat soft, very easy to start taking out. We use our typical instruments to core out the bottom half of the tumor. And then we're trying to find the normal pituitary gland, which is this thin layer right there, that thin kind of curtain that's overlying the tumor there. That's what we identify. So that's what we're trying to dissect to get to the normal plane that we want. Once we do that, we're able to shell the tumor out very nicely. We then come up to the hypothalamus. So here's where there's invasion into the third ventricle, which is this structure over here. Oh, you can't see it. This structure right here is the third ventricle. So that's what we're looking at right now. And we are able to carefully dissect this tumor from the surrounding structures in that area, and then identifying the plane that allows us to get this tumor out in a near total fashion. It was adherent to the optic chiasm there, so we did have to leave a little bit behind. But there we are, and we've debulked this tumor, and then we reconstruct with some fat and some packing, because you have a very high flow CSF leak in this location here. But the patient did well after surgery. He did take a while to wake up, but he ultimately did. We optimized his hormones. We addressed his hydrocephalus. We actually tried to remove the shunt, but the shunt actually malfunctioned, so we had to put in a new shunt, but that actually controlled his cognitive status. But he never really returned to normal. He always had some slowing cognitively. Some of it was due to the hypothalamic dysfunction. Some of it was due to hydrocephalus, and some of it was due to panhypopituitarism. So he actually unfortunately passed away 3 years later from an unrelated cause, but probably related to long-term panhypopituitarism complications. So in conclusion, brain fog or cognitive decline can affect many patients with any type of pituitary tumor. Mechanisms include hormone deficiency, hormone excess, hydrocephalus, and hypothalamic dysfunction. Really, it's key to normalize hormones up front. You don't want to wait too long on that. And you want to have very close monitoring of patients, including utilizing patient-reported outcomes to help manage your patient. I'd like to thank our team, Dr. Kelly, Dr. Griffiths, Dr. Kraus, Dr. Cohen, and our fellows for all their hard work. Thank you, and I'm happy to answer any questions.
Thank you so much for a valuable and fascinating presentation. We do have a few questions that rolled in. The first one was, what was the name of the drug that you mentioned that decreased the tumor size in the repeat patient, effectively eliminating the need for surgery?
Are we talking about for craniopharyngiomas? If it's for craniopharyngiomas, it's specifically for the papillary subtype. All of these tumors need to be genetically assessed, so that needs to be done, which can be easily done with a standard lab test for the BRAF V600D mutation. And then the medication is actually combo medications with BRAF, zelburafidine, and Mechanism. And I don't remember the exact generic names, but they're often done in combination. The oncologist, a neuro-oncologist, prescribed this very well. The only other tumor that can shrink reliably with medications is prolactinomas. They tend to be very sensitive to dopamine agonists. We didn't talk about this, but cobergoline is well known to decrease the size of over 90% of prolactinomas with just medication management. There are other hormone secreting tumors that are somewhat partially responsive to medications. So for example, for acromegaly, some of the somatostatin analogs like pasireotide, as well as the growth hormone antagonist can help shrink the tumor, although they're not going to melt the tumor away, but they may control the size of the tumor upwards of 50%. And then same thing for Cushing's disease. Some of the medications that we use can partially shrink tumors, but not reliably so.
Okay, thank you. Another question is it common for patients with panhypopituitarism to have complications with sensitivity to sunlight, they're easily sunburnt, or sun poisoning as a result of decreased melanin production?
So even though that hormone ACTH has a precursor called POMC or pro-opiomelanocorticone hormone, the production of melanin is actually regulated by the skin cells. It doesn't necessarily regulate the amount of melanin that gets to the skin. So I don't think there's any significant increase in sun poisoning or hypersensitivity in the majority of hypopituitarism patients. That said, it's not uncommon to see patients with hypopituitarism look very ashen and have a lot of pallor. And part of that is actually not from melanin, but actually the low red cell production that we see with low testosterone in men and low growth hormone in men and women. So you can see that. Could that relate to sun toxicity? Maybe, but I think it's more just a characteristic we see.
Okay, thank you. The next question, which pituitary hormones most impact cognitive function and why?
Well, I think all of them do it to a certain extent, but the main one from the pituitary gland, the anterior pituitary gland, is thyroid. If you have low thyroid hormone, then you are at significant risk of cognitive decline. I would say number 2 would be cortisol. So if you have low cortisol levels, then that can affect cognition, as we showed. Lower down, but still significant, is testosterone in men and growth hormone in men and women, which we know can affect quality of life.
Okay, thank you. And there are a couple questions asking.
Are you able to see me? Because I can't see me. It's just odd.
Yes, we see you talking.
All right.
Are there any recommended treatments or medications for brain fog in pituitary patients?
Well, so the primary thing is to identify if a patient has any of these symptoms we talked about. B, identify the underlying cause. So if it's pituitary hypopituitarism, so if it's low hormones, then you got to appropriately replace those hormones. If it's hydrocephalus, then you need to address the hydrocephalus with either drainage of fluid or taking out the tumor. If it's excess hormones, like in Cushing's disease or in gigantism, or sorry, in acromegaly, then you need to address those. And there's different set of medications as well as surgery and radiation that can help with that. And the one area that's very difficult, and I think really does not have any good known medical options, is hypothalamic dysfunction. There's no hormone to give back to the hypothalamus. It's more of a brain function issue rather than a glandular hormonal issue, even though they're related. So people try some adjuncts like Namenda, which is well known to be a neuroprotectant. People extrapolate to the dementia treatment paradigms like donepezil or Aricept, which has been shown to help in Alzheimer's. And then also Provigil and some other stimulants can be helpful in some cognitive states there. But that's the challenging one that really doesn't have a quick fix or an easy algorithm to help manage cognitive function.
Okay, we have a couple more questions. The next one is, are you able to identify if damage to blood sources or nerves are present after surgeries or gamma knife?
Yes, so for the majority of vascular problems from larger vessels, vessels that are more than 1 or 2 millimeters in diameter, you can see on an MRI if there's any signs of a small stroke. That's pretty easy to do. For those very tiny vessels, like I showed you, like the superior hypophyseal, which is less than a millimeter in diameter, you really can't tell on imaging, but you can tell based on our neurological evaluation if there's any deficits that we can identify. It's rare to see vascular, like a major blood vessel injury from gamma knife or any of the radiation options. You can get some thickening of the lining of some of the larger vessels, but it's so rare to get a true stroke from the vascular effects of gamma knife. You can get swelling and radiation effects on the normal structures, but that's a separate mechanism, not necessarily due to blood vessel obstruction or dysfunction.
Okay, next question is, have there been any correlations of brain fog seen with Rathke's cleft cysts?
Yeah, so any mass lesion can result in that. And so Rathke's cleft cysts, while the majority of the ones we operate on, probably because we catch them early, are not very large, probably less than 2 centimeters or 3 centimeters. But if you have a very large Rathke's cleft cyst that can cause pituitary gland dysfunction, that can definitely result in hypopituitarism and, as a result, brain fog. And so capturing that early and treating Rathke's cleft cysts before they cause those types of problems is really key in helping prevent that.
Okay, thank you. Next question is, after a prolactinoma is decreased with cabergoline, what percentage of patients have the prolactinoma return if cabergoline is decreased?
Ooh, that's a tough question to answer. So you're talking about a prolactin secreting tumor that had already responded to cabergoline. And so those numbers are difficult to state. Overall, the response rate to cabergoline is very good, but there is about 10% of patients or so that do not respond to cabergoline. And so that category can be divided into the complete non-responders that will have zero benefit, and then those that have a partial benefit, but the tumor still stays relatively large. Oftentimes I see patients where when we're trying to determine how to optimize their cabergoline, we will try to find the lowest dose possible that will still control their tumor. They may still have a significant tumor burden there. We just try to minimize the mass effect. But specifically, if you had a tumor that shrank completely, and then you're starting to lower your cabergoline, it's really a matter of monitoring the tumor, monitoring the prolactin levels, and dosing appropriately. But there's no concrete number to say that will affect brain fog.
Okay, thank you. And this will be our final question. Do you know of any connection to pituitary tumor and olfactory neuroblastoma?
So olfactory neuroblastoma, which is also known as esthesioneuroblastoma, originates from the olfactory bulb area, which is just right behind the nasal cavity and above the sinuses. So right above the nasal cavity and above the sinuses. So it's often more forward than the pituitary gland. However, the majority of patients with olfactory neuroblastomas or esthesioneuroblastoma tend to present late, meaning the tumor is quite large. So when the tumor gets very large, it can come very far forward, go into the brain as well as go all the way back to the pituitary gland. So some patients with olfactory neuroblastomas will have some level of pituitary gland dysfunction, but they are two separate entities. It's just they can touch and even cause compression if they get to be very large.
Okay, thank you again, Dr. Boukhardarian, for a great presentation. We really appreciate you taking the time to be with us today. This will conclude today's webinar. We appreciate you all taking the time to join us today. If you missed any part of this webinar or you would like to share it with family members or friends, it will be available on our website at www.pituitary.org in the next 24 hours. There will be a brief survey after the webinar. Please fill it out to provide us the information that we need for you. Thank you for joining us and enjoy the rest of the day.
Thank you.
Thank you again.